Dr. Abeykoon, who you met this morning, Dr. Diamond, who you met this morning, Dr. Goyal, who was one of our co-hosts, and Dr. Paul Hendrie, all have been up on the stage already, and they're going to take your questions. So we'll have a couple people roaming the room with microphones such as this one, and they'll have microphones up here as well. So give us just a moment. And there you go. Come on up, experts. Woo. We'll get you one more mic. Yeah, how does it use the sound? So I'm all right, as long as I don't have to fly. You can go either way when you fly.
Did I see a question there?
So
Here, you can use.
It's coming.
Hi, everybody. I'm a caregiver and I know a lot about ECD, but I was thinking the other day that yes, when I'm getting older, I'm losing a little my hearing, but can hearing be affected by ECD?
The answer is yes. I think it's probably underappreciated. It can be affected occasionally if the base of the skull, where the nerves that control hearing, go out. People can have. I think it's more likely they're going to have sort of like dizziness and ringing than very sort of severe hearing loss, but that's possible as well. Or sort of any of the structure sort of around that, what we call the auditory nerve. So I think it's not super common, but probably, not that rare.
I have a question for you from a patient in Australia. She asked me to ask for her. She wanted to know the pros and cons of having a knee replacement. She's to have 2 in the next 12 months, and she's worried about her ECD recurring post-op.
I've had many ECD patients get knee replacements. It's been
No
unremarkable. What?
No contraindications that I know of from that side. Yeah. Yes. I mean, of course, other medical issues and things have to be weighed. So,
but it also depends on what treatment the patient is on. So if the patient is on chemotherapy and the platelet count is low, or, then they are much more increased risk for bleeding. That's not because of ECD, but it is because of treatment, and surgery may lead to bleeding and so forth. But ECD by itself will not have a contraindication, but it is very important to pay a close attention what treatments the patient is on. Okay.
But I guess along those lines, maybe I'd ask you guys, when people are on, many of you would be on the inhibitors, the coimatinibs or the such, and going for surgeries that may or may not be related to your condition, and your doctors and anesthesiologists may ask about what medications you're on and whether you should hold them or not. And I think usually if I have someone who's under good control, I usually hold their inhibitors for their surgeries. I don't know if you tend to do the same. Yeah. So if that just adding on to your question there, that's usually what we do.
Yeah, MEK inhibitors have a theoretical risk of bleeding, but the half-life, meaning how long they stay in your system, is fairly minimal. So usually they're out of the body within 3 days. So I have people hold them for 3 days before surgery and about like a week after.
Yeah, and also depends on, type of surgery, how extensive it, if it's just, getting a dental work or tooth removed versus a major abdominal surgery. So, wound healing and things like that go into play. But yes, but that's the general practice. Closer? Okay.
There's a number of rare diseases that involve histiocytosis. Just in general terms, why are they different diseases and why do they require different therapies?
So is the question, there are many types of histiocytosis. Why are they different than each other and why do they need different treatments?
It seems like if it's histiocytosis, you don't need to give them different names.
Yeah, so it's kind of interesting you bring this up. We had a discussion yesterday at the scientific meeting about this as well. I think, yes, if you look at the actual classification of histiocytosis, a large number of diseases, they're divided into 5 groups by itself. In the last decade, we have learned that there are similarities because of these mutations. For example, Erdheim-Chester disease and Langerhans histiocytosis have similar mutational landscape. Rosai-Dorfman disease is a little different, does not have the BRAF V600E mutations. So there are similarities that we are learning about, and there are discussions about thinking differently based on the mutational landscape, but we are not there yet at this point. There's also this notion in Erdheim-Chester disease that, it is currently, at least, we have good treatments. It's still considered incurable, meaning we cannot just stop treatment and the disease never comes back. That's the general notion. Whereas in Langerhans histiocytosis, we derive a lot of experience from children who were treated. And the thought is that you can potentially cure them with chemo. But again, I think your point is very well taken that we don't understand fully why would someone with LCH with the same BRAF mutation do so well with chemo, and a BRAF mutated Erdheim-Chester disease may not respond to chemo. But we are not there yet, but there are discussions going on, and I'll let other experts chime in on that as well.
No, I think that's perfect. A lot of things happen in medicine for various reasons, and sometimes we're groupers and sometimes we're splitters. And a lot of the ways the different histiocyte disorders were originally described, including Erdheim-Chester disease, is what the clinician could see. And then we get to what the pathologist can see when they look at it under the microscope. But then in the last 10 or more years, we started to figure out what is the actual mutation is. And then that makes us rethink how we split or group things together. So, the history kind of gets us to where we have these different diagnoses and stuff, but there's some similarities and there's some differences. And we want to make sure that we use the drugs that can treat them all in a similar fashion, but also recognize the differences and what we have to do differently in those specific situations.
Sorry, I just have a question about swollen feet to the point where it's painful to walk. I'm just curious if that's a symptom of ECD or a side effect of treatment.
Swollen feet.
Yeah, it could be a side effect of treatment and it could be the disease as well. So it needs a little bit more details that we can meet offline as well, because if the disease is involved in, where the lymphatic system being drained in the legs and it is obstructed, then you have swollen feet. That is because of the disease. But if it is secondary to treatments, that can have an effect in swollen feet as well. So it is difficult to answer that question specifically by the history that you just gave, but I do understand the patient's privacy here matters as well. So happy to meet offline and, answer, but answering your question, it can be both.
Yeah, I've had patients have edema or swelling of the feet on cobimetinib. I don't know if others have had that experience. That's been actually challenging to manage sometimes. ECD by itself can affect it. You can have swollen feet for various reasons. You can have low protein in your blood. Your kidney may be wasting protein, and you can have low albumin, and that can lead to swollen feet as well. Or it can also affect the heart, and that affects the function of the heart, and prevents the fluid from going back. So there are, like Dr. Abeykoon said, so there are these various reasons that you could have swelling in the legs. But yes, it is seen. If you ask in general in patients with ECD, definitely we have seen that.
Hi there. I was wondering if you could, it seems like early diagnosis is, the benefits of that would be pretty obvious, but wondering if you could speak to, from a doctor's standpoint, the benefits that you see that could come from being able to diagnose Erdheim-Chester sooner.
Yeah, well, there's things that can happen as a disease like Erdheim-Chester progresses. And some things can be reversible and some things may not be completely reversible. And so one of the thoughts is the earlier you treat, you get before you have these complications that may not be reversible when you do treat. So that's one of the benefits. And I think that's a definite benefit. One that we don't necessarily know is if we treat someone earlier, are we more likely to actually get to this cure point that was talked about, rather than this chronic disease? And I think it's too early to know that much. I don't know if you want to comment on whether earlier treatment might get to the point where we'll be able to have people off treatment or not. But that would be the hope, Barry. But definitely getting treatment in before there's complications that may not be reversible is a motivation.
Yeah, I would say that if to the extent that the disease causes health problems, one, by sort of causing organ dysfunction, then you can prevent or lessen that earlier. And then on the other hand, to the extent that the disease causes symptoms by the body being overly inflamed, then people would hopefully feel better sooner if they're treated earlier.
Thanks, doctors. I have two questions unrelated. First is, unlike Barry's reaction to, oh, I have cancer, in 2016, the declaration by WHO that Erdheim-Chester disease is a neoplasm is actually kind of good news to the effect that you can tell people, oh, I have something that is definitely a cancer and could lead to recognized treatments or at least pathways to it. Is the reason why it's called a neoplasm because the cells accumulate in places they're not supposed to, rather than a proliferative cancer?
Yeah, so that is a good question. And I like to answer this question for my patients when I see them. So cancer definition of a cancer is it gives rise to one group of cells, which we call clonal. So one group of cells become abnormal because of a mutation or something that happens in their DNA. And then that group of cells will proliferate to the point that it will give rise to a cancer. But it is one group of a family of cells that give rise. But the flip side of the coin is like, if it is not a cancer, can it be inflammation? So the difference between the inflammation and a cancer means in inflammation, it's not one group of cells. It's like many groups acting to being an inflamed and producing chemicals that will make you itch, having you fever and have a rash and so forth. So that is the basic difference between a cancer, which is clonal. That means a group of cells get mutated or genetically altered, and it goes crazy and then proliferate to the point that the patient will have signs and symptoms. But the inflammation, on the other hand, is not a single group of cells, not a clone, but it is multiple groups of cells that act and they don't have what we call that genetic mutations that we detected on that clone in the cancer.
Okay, here's my second question. I was diagnosed in 2002, and as some of the panelists have expressed, early diagnosis is really key, of course, to treatment and lifelong care. So doctors have had a long time to figure out what to do with me. Early on, I started on a treatment with Intron, which I think is defined as alpha interferon, and it had a number of unpleasant side effects. I think one of them was that I had a lot of pain and fatigue. So early on, I was put on not baclofen, but another drug called Zanaflex. I think it's tizanidine. Anyway, I think these are antispasmodics. After taking it for a couple of months, I noticed that I was extremely weak. I was trying to hold a newspaper and it was slipping between my fingers. Hopefully now these sorts of pain manifestations don't plague people too much, but would there be alternative treatments rather than using these type of antispasmodic drugs?
You're talking about from the pain that was the side effect of the interferon? Oh my. Fortunately, and the interferon has kind of been eclipsed for the most part by targeted therapies. I haven't given it in quite some time, so I'm not familiar with the toxicity management, but we still use tizanidine for, often for various kinds of muscle spasticity.
Yeah, I haven't used interferon in a while, actually. But yes, the side effects are challenging to manage sometimes. It does work. When I used it in fellowship and a couple of patients, it worked, but the side effects were, in some it works well. The side effects are manageable, some it's not. But yeah, I don't have experience now in managing the pain from that directly.
Well, I was just going to comment one that, you're like many of my patients who have had this disease a long time, and your medical knowledge is very impressive at this point. On not just being able to pronounce all the different names of the drugs, but recognizing the different side effects along the way. So, I think we should often give our patients a honorary MD at some point. But in Eli's talk earlier about medications, sometimes dose reductions can help with when these side effects come up. And then there was another talk on pain management and such, and sometimes that non-medication interventions can help as far as working with OT and physical therapy and stuff. And you're right, sometimes the intervention, the other medicine then has its own side effects as well. And so we always encourage people to look, sometimes you need another medicine to treat a medicine side effect, but sometimes you want to look at, can you just reduce the dose, or can you do non-medication interventions?
So I know the strategy with these new inhibitors is ultimately to reduce them over time. But one of the things I learned, like with brain, is, you might need a stronger dose as you have brain involvement. You might be on a stronger dose for a longer period. So I know we don't have decades of experience yet because they're new, but, as we start having a survivor population that has decades of experience, what we'll be looking for. So as you have get a decade or two, what we'll be looking for, what we'll be looking for is the population. You have a decade, another decade of people who have been like on Zelboraf, like a higher dose of Zelboraf for 2 decades. I don't want to speculate, but what could emerge and what will we be looking for?
Yeah, that's a good plug-in for my survivor study. Thank you. You'll get your check for that. so that's really one of the, and I'll talk about that later, one of the nice thing is, with the targeted therapies that, we've halted the disease progression. We have converted it into more of a chronic disease. So you are on these pills for a long time indeed. And, we don't know a lot of the symptoms that the patients still have from the disease or from the drug. And it's not been systematically assessed yet. And that needs to be answered. And if we are saying that, okay, well, it's fine to be on low dose, but that's part of it is also, how Dr. Diamond said voodoo, we are trying to, it's not been systematically evaluated, but we don't know what will happen if you're on that for 10 years, let's say, or 20 years. So as the population, or 40, yeah. So, as the survivor population ages, we will have to answer that question. And that's why, it's a step in the right direction. Now, we do borrow some of this from melanoma literature as well, but melanoma, we don't use the Zelboraf by itself, but those drugs have been around for a while in melanoma. We combine them, and we do know that there are long-term issues that can happen if you combine them, different side effects. There are some side effects that can be lessened by combining the two, but there are some side effects that can be multiplied or increased. But we don't know how it's going to pan out in histiocytosis. So I don't know the answer. If others smarter than me have them.
So, I don't know if you were asking about what to look for neurologically. I don't know if that's what you were asking. So the first ECD patient treated with vemurafenib was early 2012. So we have, 10, 11 years. And I would say, because I follow many of them, there's a small subset who have very, very slowly progressive speech imbalance problems without changes in their MRI. So I think that objective assessment of speech imbalance, like over time, may help sort of detect what can be a very, very, very slow drift that, may be imperceptible month to month to month, but then, if you sort of people look back a year or two, has been getting worse.
Yeah, and I would just add on that, you're asking us the question, but really we may be asking you all the question as we go forward. Melanoma was mentioned here, but actually, the histiocyte disorders do much better long-term on this therapy. And so we'll actually be training back the melanoma people because you guys are surviving so much better with it. And so, and I'll use the example of a disease that we've been treating for 20 years with a targeted therapy, chronic myeloid leukemia, which we have imatinib that we've had for a long time. And only now, we'll figure out, well, what are some of the longer term, because the clinical studies can only last for a certain period of time because we've got to get the FDA approval that we get done. But the long-term results, they take time, and it takes us listening to the patients and saying, okay, not writing off, I have, this other thing, and say, oh no, it's not the drug, it's something else. The important part is to let your doctor know if you're having new symptoms, and it may be the drug because they haven't been around for 20 or 40 years. Is that what you wanted? The 40 or 50 years or what? Okay. Yeah. We'll see. Hopefully I'll be here in 40 years to ask you back on that.
Hi, my name is Jamie Lee. I'm from North Carolina. I have a question for you. I'm in remission. I've been for 2 years. Although I do have some endocrine problems like my pseudoporphyria effect, and my bone still hurts. Is that normal when you're in remission?
Was the question to have, is it normal to have pain despite having a quote unquote good looking scan? Unfortunately, very common. Yeah, there's quite a mismatch between what you see on a scan and how people feel, because there's a footprint of the disease and there's the footprint of treatment.
Yes, there was a talk yesterday about disease clusters and maybe environmental factors with ECD. Is there any evidence of that? Like, for example, Roundup exposure for other lymphomas? Are there any environmental factors that might lead to ECD?
Yeah, none that I'm aware of. It's being looked into. Generally, environmentally related disease, and at least in my mind, would be a little more common and would happen in areas. But I think the study you saw, it's still pretty early data. So we still need to investigate further whether there are areas, and maybe worth exploring at some point if we pool all our cases and see zip codes where most of the cases are coming from and so forth. But there are ways to do that. Right now, we don't have, I get this question often because, and also when people hear the word mutation, they almost think about, is something like radiation, some chemical is causing that mutation. I don't think we have any evidence right now.
Hi, I'm Doug Boone. I just want to make a point, at least that's something that's impressed me. I think I saw a slide that earlier there's 873 diagnosed. And I don't know if that's currently or ever, but I keep dividing that by 8 billion or 9 billion or whatever the population of the world is. And I want to thank and appreciate the focus that you guys have put on this disease, and certainly Kathy, because, logically, it doesn't seem like a lot of attention should be focused on this disease, and certainly appreciate your efforts and what you're doing and what Kathy's done to help, my wife and all those others that have this. So do you think, is that 873, you think there's a lot more, or that's about it?
I think there is a lot more. I'm originally from Sri Lanka. So in that part of the world, Sri Lanka, India, the developing countries, these diseases do exist, but there is no knowledge or the expertise to diagnose. Because if you may recall, to make an accurate diagnosis of Erdheim-Chester disease, you had to have the pathologist, the radiologist, the neurologist, the hematologist, all the internal medicine doctors. So in the US and in developed countries, you can do it because the PET scans are very abundant, and there you have to wait 6 months to get one PET scan. So it is impossible to do diagnosis accurately. So it is an underestimate, to be honest with the 800 something number that you just talked. So I think these numbers are high, but at the moment, what we can quote is what we have, scientifically.
Kathy, can you just, that number was the current members that you identified in the registry? That 800?
The 800 is the number of patients we'd had registered since we began.
That was registered since. Yeah,
2008.
So there's a large number of people who are diagnosed that's not registered. And then, as was stated, we're probably just seeing the tip of the iceberg still. There's still a lot of people. So, yes, we're all up here, and we, whether it is just 800, we want to make sure that those 800 do better. But we're also up here because we want to, make sure that all those other, 10 times more, whatever, get diagnosed and get treatment as well.
Yeah, I want to thank everybody. This is our first seminar, and I want to thank everybody for the greet last night, all your personal stories. They all seem to come together, and kind of like what Jeff has here. So I want to thank you all for that. My actual question is, the disease is wrapped around his kidneys, and the concern was to keep the kidneys functioning. Obviously, you need blood. in doing that, his blood pressure's been up, down, up more than down. Has stents in the arteries been used much to accomplish the blood flow to the arteries? Or isn't there much history on using stents? Does anybody know?
There's a rich history of using stents to open up the arteries to the kidney. In the targeted therapy era, it has been needed less, but it has been done many, many times. Many of my patients sort of what I call legacy, sort of diagnosed a long time ago, have renal artery stents.
So it would be a success. Well, I can't say successful because it'd be a chance if we had to go that route then, right?
I mean, I'm just saying all of the particulars of the case put aside, the concept is a viable one and it's been done many times.
Okay. Thank you.
Hello?
I'm sorry.
Somebody else?
I'm Colleen. I'm actually Anya's mom. So the case that was up from Dr. Abeykoon earlier, and I'm going to follow up on your CNS long-term because she's 25 now and she was 23 when she got on that treatment. So when you mentioned, Dr. Diamond, that slow progression of ECD over maybe a decade or more, is that, you believe, a progression from possibly the effect of the drug itself or slight progression from the ECD, even while kind of apparently stable on a drug?
So I think that there's a footprint of the disease on the brain that is not currently measured and appreciated. I don't think that it's because of the treatment.
Okay.
And so I think that it's some microscopic or not, it's an effect of the disease that we're not currently capturing, or that is not being adequately addressed because the drugs don't get into the brain well.
Hello, I have a question. My name is Susan Gerard, back here. The question I have is, it seems like there's been research and a lot of time put into if you're BRAF positive or if you have specific MEK inhibitors that you can target. But for those of us who don't have any of that, is there research being done or trials being done to address other gene mutations?
Yeah, as Dr. Abeykoon talked about today, and as in Anya's case, we are seeing now, since we have been using these targeted therapies more and more, that there may be some other mutations that could be driving a small subset of these cases. And there may be ways to target them. And we are also, so there are ongoing discussions and trials in planning actually, and we discussed about them yesterday, where we are looking at what if we were to just, there's a relay signaling in that pathway. You can block the RAF, you can block the MEK. What if you just block the relay altogether at the very end? So you don't have to figure out, oh, what is the mutation and what's not. But for now, as we know it, how the guidelines stand is, MEK inhibitors can still work among people who don't have any mutation that we found. And it may be just a function of the test itself, that we may have not picked the mutation. And sometimes we retest it also on a repeat biopsy. So the MEK inhibitor, cobimetinib, can still work. But yes, if you have a mutation like a MAP2K1, KRAS, that's more likely, we know that's going to work. But still, it's fair, it's good, it's okay to try. And that's the guidelines, to try a MEK inhibitor if you don't have a targetable mutation identified. But we are already in planning. This year itself, I can say we are planning for other trials, and you'll be hearing about them to target other aspects. What if we were to not even worry about what mutation you have and just block the entire mechanism by which the disease happens and so forth? So yeah, thank you.
And also, it is important to remember that although in one given time point, you may not see a mutation in the cancer, you may see a mutation if you biopsy in after 3 years. So it is very important to make sure what we are treating. So before commencing treatment, if possible, it is important to get the biopsy and make sure that you do the next genetic analysis and see whether you can find any targeted mutations. So because it is very difficult, it is actually not correct to rely on a mutation profile that has been evaluated like 5 years ago. And then now the patient is getting worse and the treatment is, the cancer is progressing, and you rely on that sequencing. That is not correct. And it is not only in ECD, it is not correct in breast cancer, it is not correct in lung cancer. So cancer by itself, you need, because these cancers evolve over time. So we need to make sure what we are treating.
I'll just add, but what you're pointing out, which is that, we're the slice of the pie that doesn't have, the off switch is getting smaller, but it still exists. There's people who, for whatever reason, they can't get another biopsy because of where it is, or it's been sequenced 5 times up and down and there's no mutation. So that represents an unmet need that is small at the moment, thankfully, but it is still a very important one. And there are, like Dr. Goyal mentioned, there are other ideas that could potentially work regardless of the mutation.
I just wanted to stay, we're going to take about 10 more minutes with this panel.
Okay, my name is Janet Bundy, and I want to know who you're gonna get biopsies from.
She was wondering where you can get biopsies from.
Yeah, I guess there's 2 ways I could interpret the question. We can take biopsies pretty much from anywhere there's a lesion. Sometimes you need to go to a different procedurist to do it, whether it's in the brain or in the belly, or sometimes just from someone who has a skin lesion. So we can take biopsies from a number of different places. But if the question is, where can you get the biopsy performed and you're not getting it where you want, please contact one of our centers and we'll get you set up. So I didn't know which aspect of the biopsy question that you wanted, but if you're questioning, can you get a biopsy done that you haven't been able to get done, please contact one of our centers and hopefully we can get you set up.
Yeah, and I'll just add to that, one of the things that we clarified in the updated guidelines was, sites of biopsy. A lot of times when we looked at folks who got biopsy, a lot of times from ECD, it was from the bone. A lot of times also from, the soft tissue around the kidneys or on the skin. One of the things to keep in mind in general, as just going back to the point Dr. Abeykoon was making is, bone biopsies, traditionally, they use a method that can damage the DNA of the cells. So if you somebody has histiocytosis and you want to do next generation sequencing or NGS or BRAF testing, those tests may not work if you have that acid-based processing on that bone. So just if you're getting a biopsy of a bone, just, it's in the guidelines, we clarified that to make it clear that please use less acidic methods to process it, or to make a comment, that we will be needing DNA analysis on this. So maybe save a non-decalcified sample for that. So there are some nuances there, but your doctor should be aware of them.
Hi, it's Susan Liu, and thank you very much to all of you, to the medical professionals, the researchers, to the wonderful staff at Erdheim-Chester Disease Global Alliance, and all of you for attending with your patient questions and concerns, and the caregivers who are invaluable. I am taking care of Joel, who was diagnosed in 2002, and I have just 2 brief questions that may be relevant and important to all of us in this room. Joel, when he was first diagnosed, no doctors and no one heard of Erdheim-Chester disease. And he was diagnosed because he had lesions on his long bones. And so he had an early diagnosis, but it impacted his kidneys. And so he had to have a nephrostomy, tubes running out of his back. And then he also had a tumor in his lung, which turned out to be benign, fortunately, but that was removed. And so he's had about 40, almost 50 surgeries since 2002. and he's going through chemotherapy medications for which we seek compassionate care. My two questions are, through the 20 years that he's had this illness, when he had a life expectancy of 2 to 3 years from his diagnosis, I've always wondered, with all of his suffering, his courage of going through chemotherapy medications, through all of his surgeries with general anesthesia, is it possible for stem cell to take care of Erdheim-Chester disease as some means of a possible cure? And my second question is it possible for blood mutations to be a tool now regarding Erdheim-Chester disease?
Regarding hematopoietic stem cell transplant, which I think you're referring to, you're correct in that this disease arises from the cells in the bone marrow. But we don't have a lot of experience with that treatment for this particular disease. And the trick is in some diseases which involve these cells is where are they in the body? Do they hide? And so sometimes, although you're replacing most of the bone marrow, you don't replace all the malignant cells, and it could come back. And I think that's one of my fears with a disease like this. That's the cells are growing in areas that might not get treated by the transplant. It may not be successful, and there are a lot of toxicities from it. But there is, again, hope that maybe, thank you for the good word, my 4-letter word for the day, for that it could be possible. But right now, I'm not sure that I would venture into it up front. I'd be a little bit hesitant to go through a transplant for this disease.
Yeah, there were a handful of cases reported with transplant. When we say stem cell transplant, getting stem cells from someone else, very toxic procedure, high mortality and long-term morbidity, well known. We have data from Langerhans cell histiocytosis, and I think even in that, it's fallen out of favor. Now we have targeted therapy for relapse disease. It's being used less and less for the stem cell transplant piece to that. But yes, I do acknowledge the suffering, and that's what we're trying to capture there, to figure out the number of what are the procedures, what are the health problems you're having once you're living with the disease. The other piece to the question is the blood-based testing. There have been some data about testing, since BRAF was the first mutation sort of seen in more than half of the cases, to look at in the blood whether it tracks. And there are some data to suggest that yes, maybe you can track it once you're on the drug. If you measure the volume of there are ways to measure it, and there are different tests to do it. Whether you check it in a cell or you check it how much is it's just floating around DNA that's being shed. It's not, I have to say, and others can correct me if I'm wrong, it's not completely panned out, because there are cases with the mutation that we don't find them in the blood. But if we find the mutation, then we can track it. But we don't know, we are not there yet, and we are building it into trials whether we can, figure out a way, as we have done in other cancers that Dr. Hendrie was talking about, like CML. Can we track that level of mutation with such a sensitive test, and we can get to a point where, it's undetectable, confidently saying that, okay, well, now we can take a break from treatment and then measure it again. And then maybe, so it'll be in an ideal world, we would get to that blood-based analysis. We are doing studies still. We don't have the right way to use those tests.
I think we had one
more question. Yeah.
Yes, I have a follow-on question to the gentleman here in the red shirt who raised the stent question. So in some of us, we have fairly significant vascular involvement, at least I do. And in talking long-term, what happens next, if and when we need to do some interventional therapy in a particular area, I have the aortic coating, and the large branching vessels tend to stenose. So do any of you in your practice have patients where you have used stents, drug-eluting stents or otherwise, in the peripheral vessels that have been robust and held up well? My concern is we really don't know what this material is, this inflammatory material from ECD. Does it act like normal plaque when you stent it? Do you have any experience with that?
I have experience with kidney artery stenting, and then a couple patients who've had stents or some kind of opening procedures in the brain, and the stents have all lasted in my experience. And then, in ECD, the infiltrate is on the outside of the vessel, not on the inside. So I think just from a hypothetical standpoint, intervening from the inside is sort of conceptually okay. And the experience that we have with people who've been stented has been favorable, albeit limited.
Yeah, and I'm not sure, in the, most of these stents are not drug-eluting stents, and I'm not sure whether there's a role there or not, given that this is an external compression. But I don't think we have a cardiologist or a vascular surgeon up on the stage, so. Well, thank you all very much.
Thank you, everyone.
Is that it?
That's great. Terrific. Thank you so much.